interesting session. This is session 2 of the last session that we had with Dr. Abhilash Koratala, who has a great expertise in the field of point of care ultrasound in nephrology. We're happy to have him here to share his experience regarding an important and exciting topic in the field of nephrology, that is nothing but the volume assessment. To moderate this session, we have with us Dr. Seerapani Gopalani, who is a senior consultant nephrologist from Citizens Hospital. Without much ado, I invite the moderator to continue with the further proceedings. Over to Dr. Seerapani.
Thank you, Dr. Manjusha, and welcome, Dr. Abhilash Koratala. As nephrologists, we deal most of our time making clinical judgments about the volume status of our patients. And we use a different variety of parameters. Some of them are clinical, like blood pressure, pulse rate, pedal edema. And some of them are non-clinical. For example, I say, well, my gut feeling is that this patient is probably volume depleted. Let me try giving some fluids to see what happens. So the objective measures we use are not infallible. And on top, there is a significant dissonance amongst our clinicians. And not use the word dissonance lightly. I'm sure everyone remembers the mental trauma we had to go through when someone else disagrees with our fluid balance assessment. So we need other tools to get this correct. So I welcome everyone on this webinar to add another interesting tutorial on the use of point of care ultrasound, dubbed as POCUS, to help us make better clinical decisions. This session by Dr. Abhilash, I'm sure, is going to be enthralling and educational. And without further ado, I would let Dr. Abhilash start teaching us about the use of ultrasound in volume assessment. I would request everyone, if you have any questions, to type them in the chat box, and then we'll try and let the speaker answer at the end of the session. Over to you, Dr. Abhilash.
Yeah, thank you so much. Okay, is a full screen mode visible? Okay, sounds good. Okay, so let's talk about fluid status assessment using point of care ultrasonography. And it's not really comprehensive evaluation of fluid status, but more of a basic overview. Because when we say comprehensive, by definition, it involves utilizing spectral Doppler and advanced applications. But prior to that, we need to know how, like, what is the basic approach and the basic cardiac views and how does lung ultrasound look like and all those things before we go to further assessment. And okay, I do not have any disclosures. And yeah, as you were just talking about, nephrology practice primarily involves making decisions about whether to give fluid or remove fluid in the context of blood pressure disorders and electrolyte disorders. So we need to be able to objectively assess fluid status, if not accurately. And so far, whatever we do depends upon utilization of clinical parameters and laboratory data. They are quite variable and depends upon how severe the patient's underlying condition is. And when we prescribe IV fluids, we definitely realize that they are like drugs, and we need to have specific indication to give IV fluids as opposed to just empirically giving them, at least in nephrology practice. And it's not a secret that we sometimes use intravenous fluids very liberally and really don't pay attention to what's the underlying medical status. So we do know that fluid overload causes several pathologic sequelae in the body. It affects almost every organ. For example, in lungs, it causes impaired gas exchange and increased work of breathing. In the heart, conduction abnormalities, impaired contractility, and impaired relaxation. Acute kidney injury, and the person has increased intra-abdominal pressure from ascites, it can cause renal hypoperfusion, and impaired cognition, altered mental status, and delirium because of cerebral congestion. In the liver, it can cause impaired synthetic function and cholestasis. In the gut, malabsorption and ileus. In the skin, it causes poor wound healing, pressure ulcers, and so on. So basically, fluid overload causes multi-system effects. And this is a recent meta-analysis looking at the effect of fluid overload on mortality. So fluid overload is generally defined as increase in weight by more than 5% after hospital admission. And both fluid overload and positive cumulative fluid balance after hospital admission, they were associated with. The thing is that for 1 liter of increase in cumulative fluid balance, mortality increased by a factor of 1.12. So that's pretty significant, because 1 liter of positive fluid balance, we might not really pay attention to in the grand scheme of things. And as a reminder from the last talk, insonation or using point of care ultrasonography is a component of physical examination. It's just in addition to inspection, palpation, percussion, and auscultation, it's just another part of examination. And like we carry all these things, we used to, right? As medical students, we used to carry a reflex hammer, flashlight, tape, stethoscope, tuning fork, and all these things. And sonoscope or ultrasound is just another point of care device as an addition to these things. And from my last talk to now, another medical school in the US has joined this POCUS revolution of giving handheld ultrasound devices to all their medical students. Generally, in the first year of medical, give all the students stethoscope. That's quite good ceremony. And during that, the new trend is to point of care ultrasound devices to all these medical students. So more and more ultrasound enabled physicians are coming out. Okay, so regarding the volume status assessment, we call this the pump, pipes, and leaks model. So volume status is not exactly just the volume status assessment. In other words, it's hemodynamic assessment at the bedside. When we are assessing hemodynamics, we need to pay attention to the pump, so how the heart is beating. And pipes, so looking at the inferior vena cava to look at the right atrial pressure, and look further down at hepatic vein, portal vein, renal parenchymal vein to see how the organs are feeling congestion. And leaks are leaky when there is extravascular lung water or ascites in the abdomen. All these things need to be taken into consideration when making decisions that are related to fluid status. And when we take a closer look at the hemodynamic circuit, so this figure appears complex. So let's go from the left side of the heart. So hemodynamics is a whole circuit, right? And we are just assessing flows or pressures at different parts of this hemodynamic circuit. And this diagram involves Doppler ultrasonography that I'm not going to talk today, but I'm just trying to say that this is not really that complex that, as it appears. So here is the left ventricle and right ventricle, right? So left ventricle outflow tract. By measuring the flows here, we know how much blood you are pumping out of the heart, that is stroke volume. And similarly, at the same point, you can assess if the patient is fluid responsive or not. What is fluid responsiveness? It's just ability to increase your stroke volume in addition to whatever preload you are adding. So that's that point. And if you measure the flows at mitral valve and pulmonary veins, you'll be able to know what is the left ventricular filling pressure. That means how is the left ventricle relaxing. And as you go further up into the lung, you can see with ultrasound if there is any extravascular lung water, whether there is pulmonary edema or pleural effusion or consolidation and so on. And then you go further back into the circuit, and here you have right ventricular outflow tract. So right ventricular outflow tract flow measurements will tell you what is the resistance being offered to the blood flow. So for example, it could be because of left heart failure itself, or COPD or lung fibrosis or something that increases resistance to right-sided flow. And when you go further backwards, you have the tricuspid wall. So if there is resistance to the forward flow of the right ventricle, there is more tricuspid regurgitation going back into the right atrium. And as you go further backwards, you are looking at the IVC. IVC is nothing but a tube that's connected to the right atrium. So if the right atrial pressure is high, you're going to have a dilated IVC. And farther from IVC, you have all these veins, splenic vein, hepatic vein, portal vein, renal parenchymal vein, femoral vein, and so on. I mean, there are several points that you can measure the flows at that will tell you if there is any congestion at the organ level. Because as soon as the right atrial pressure is high, the IVC is going to dilate. And after that, if the blood flow is altered at the organ level or not, we can know by utilizing Doppler ultrasonography. So this is basically bedside hemodynamic assessment in a nutshell. And of course, the last part is you look at the intra-abdominal fluid also. That is a site test. And as an addition, you might also want to DVT evaluation in a patient who is hypotensive and who doesn't have pulmonary edema with the suspicion of ruling out pulmonary embolism. So that's what it is. So without too much delay, let's go into our basic assessment. This is just a reminder from the previous talk that when you look at an ultrasound image, things that are closer to the probe are on the top of the image, and things that are farther from the probe are at the bottom of the image. So that rule applies to wherever you scan in the body. And that will tell you, if you know where your probe is, that will tell you the laterality or whether it's anterior, posterior, or lateral, medial, depending on your probe position. And this green thing here is the screen indicator, and it can be a letter or symbol depending on the manufacturer, and that corresponds to a probe orientation marker. So every ultrasound probe has a marker. So is the probe here? There is an orange dot, and similarly there can be a LED lamp or something like that. Oops, sorry. Yeah, and that corresponds to the screen indicator. So if your probe indicator is towards your head, whatever part of the ultrasound image is here is towards patient's head. So with that, let's start with the lungs. Lung ultrasound, you can also consider that as sonoauscultation. This is a study that was published in 2004. It was a study in ARDS patients, relatively low sample volume, but this is the one by father of lung ultrasound, Dr. Lichtenstein. This has piqued the interest of many ICU doctors to start doing lung ultrasound. Prior to that, lung ultrasound was really considered practical because if you remember, we said air is enemy of ultrasound. Air reflects ultrasound. So any air-filled organ, whether it's lung or bowel, it's hard to ultrasound that because the underlying air is going to reflect back your ultrasound. So lung was never really ultrasounded. But what Dr. Lichtenstein and colleagues found was that if you are able to analyze distinct artifacts, the lung will give you, whether it's when it's filled with air or when it has a lot of water, you might be able to quantify the congestion. So those are B lines. So we'll see what they are. But in the study, what they found was that lung ultrasound was more sensitive than auscultation and also chest radiography for detection of pleural effusion, alveolar consolidation, and alveolar interstitial syndrome, that is pulmonary edema. And you can see that sensitivities were significantly higher. And we are used to doing auscultation, right? And auscultation, it's way less sensitive, and the sensitivity even decreases further when you are in intensive care setting, when the alarms are beeping, or even in the outpatient dialysis unit. Those machines are always beeping, and nobody knows like what you are really listening to. And most of the time we listen with the patient's clothes on for various reasons. So that also impairs your sound conduction, and there are so many problems. And also in ICUs, most of us are used to getting daily chest x-rays. But if you're able to do lung ultrasound, all this need is obviated. And not only in ARDS patients, but in dialysis patients also, physical examination has shown to be much less sensitive. For example, the sensitivity of lung crackles and peripheral edema was only about 9 and 3% to detect significant pulmonary congestion that was otherwise detected by lung ultrasound. And there was another study in ICU patients. It's a general ICU cohort, not exactly ARDS. It was close to 1,000 patients. And about 300 patients had pulmonary edema, and among those, auscultation was normal in about 50% patients. And this is an ICU cohort. You're making life-saving decisions in these people every day. And the next question you might ask is, oh, you're saying it's more sensitive than your auscultation or even chest x-ray, but why do we care? If the patient is not symptomatic, does it have any prognostic significance? Yes, this is a study in hemodialysis patients, close to 400 sample volume. And in this, in patients who had more than 60 B lines are vertical artifacts in the lung which indicate extravascular lung water. You can count those lines. They are analogous to Kerley B lines on X-ray. So people with more than 60 B lines on lung ultrasound, they had significantly higher all-cause mortality and overall fatal and non-fatal cardiac events. And the interesting thing is that 71% of the patients who had 15 to 60 B lines, even 15 to 60 B lines is a risk factor. So those were completely asymptomatic. So even asymptomatic lung congestion matters. So how does a normal lung look like? As I said, you do not see a lung tissue because air is lung tissue only when there is lung collapse or lung consolidation. So normal lung looks like this. So you place the probe, and you can use a curvilinear probe, that is the abdominal probe, or a phased array or cardiac probe to do the lung ultrasound. And if you're a pediatric person, you can also use that this microarray probe. And so when you see this lung image, all you are seeing here is a bright horizontal line, that is the pleural line. So parietal pleura and visceral pleura appear as single bright line. And beyond that, you see what appears to be mirror reflections of the pleural line. Those horizontal lines are called A lines. And you see A lines when lung is filled with air. And let's see how they form. So A lines are reverberation artifact. And from the previous talk, I mentioned that time is equal to distance in the ultrasound world, which means you send out a wave, and depending upon how long the returning echoes take, so the longer the returning echoes take to reach back to the probe, the deeper a structure is depicted on the screen. So in this example here, the probe is on your skin and you have lung underneath that, and some waves are hitting the pleura and going back to the probe. That's depicted as the bright pleural line. And some of the waves, because of the underlying air, they're reflected back and forth between the probe face and pleura back. So here, this set of waves are taking twice as much time to reach back to the probe compared to the original reflection from the pleural line. So the machine thinks there is another pleural line equidistant from the pleura. And similarly, this set of waves are taking 3 times as much time, and this set of waves are taking 4 times as much time to reach back to the ultrasound machine. So every time the machine thinks there is another pleural line at an equal distance. So that's how A lines are formed. And as you go to the end of the screen, the intensity of the A lines decreases. So now you go back to the image, now you can see these are all reflections of pleural line. And you see more horizontal lines, these are probably reflections of the deep fascia inside the skin. But regardless, you can call everything as A lines, or some people like to call pleural reflections as A lines, these equidistant things, and in between the facial reflections as sub A lines. It doesn't matter what you call, but lung is filled with air, that's important. And so where do you auscultate the lung, right? Or where do you sono-auscultate the lung? There are different scan zones described. First, look at this left lower quadrant image. Previously, in the prognostic slide, I told you that more than 60 B lines. Let's back off a little bit. B lines we did not see yet, but okay, so there are different types of auscultation. Basically, if the patient is acutely symptomatic and you are suspecting there is pulmonary edema, it's okay as long as you auscultate some upper zones, like zone 1 here and another zone here. If you are able to find evidence of pulmonary congestion, the patient is congested. But in asymptomatic patients, you probably need to sono-auscultate more zones. The commonly used technique is the 8-zone technique. 8 zones involve 4 zones on each side. You have a parasternal line, anterior axillary line, and posterior axillary line, and you draw a horizontal line just below the nipple, and you have 4 zones, 1, 2, 3, and 4. And lateral zones are very important, especially in supine patients, because fluid is going to go to the dependent areas. And you do the same thing on the right side. This is the most popular and works for most patients admitted to the hospital. And some studies also describe 6-zone method, where you would do one zone anteriorly, somewhere in the mid-clavicular area, second or third intercostal space, one in the anterior axillary line, and another one in the mid-axillary line. You can do this one also. And this is the really comprehensive 28-zone scan. What it does is it divides, basically it involves auscultation of individual rib interspaces or individual intercostal spaces. So you have a parasternal line here, mid-clavicular line, anterior axillary line, and mid-axillary line. And along these lines, you auscultate every intercostal space from second to fifth intercostal space on the right, which makes it 16 zones on the right, and from second to fourth intercostal spaces on the left, which makes it 12 zones. Less zones on the left because there is heart interference on the left. But the point is you auscultate 28 zones or 28 intercostal spaces. This is primarily used in asymptomatic patients, that is in the outpatient dialysis unit. Whatever studies you have so far, like 90% of them use this comprehensive scanning method. And posterior zones you should auscultate when you are suspecting pneumonia. Say atypical pneumonias occur in different scan zones, so as to not to miss any posterior aspect. You also want to scan. That is particularly important in the COVID era. So basically what you do is you do the 8-zone regular lung ultrasound followed by sono auscultation of posterior zones. So that's briefly about lung scanning zones. And we said we need to use a curvilinear probe or a phased array probe to look at the lung. But if you want to take a closer look at the pleura, use a linear probe, because linear probe is a high resolution probe and offers better visualization of the superficial structures. So this is how the pleural line appears. So here is one rib, here is another rib. You can say this is one zone of auscultation or one rib interspace or one intercostal space. So the bright pleural line here, it seems to shimmer or it seems to like slightly moving or shining. That is called pleural sliding. So basically if the pleura is sliding, that is normal. And you see absent pleural sliding in pneumothorax. That's the importance of knowing about pleural sliding. Of course, you can see when there is pleurodesis or like a large COPD bulla or something like that, with such exceptions. In general, in the right clinical context, if you are looking for absent pleural sliding, we are primarily looking for pneumothorax. And if you place the M mode cursor on shimmering pleural line, this is how it appears like. And M mode, you remember, right? So when you turn on the M mode or the motion mode, you get a line, and the machine depicts whatever is beneath that line over a period of time. And so the tissues, so here is a pleural line in the middle of the image, right? And the tissues above that are stationary. So on the M mode, they just appear like lines. That's normal, these horizontal lines. And this bright line here is the pleural line. And because the pleural line is sliding, underneath that, there is all grainy appearance on M mode. And that's compared to a sandy beach. That's normal appearance on M mode. And in case of a pneumothorax, there is no pleural sliding. So even beneath the pleural line, so pleural line is here somewhere, and beneath the pleural line also, everything appears like horizontal lines, and that's called a barcode sign. And that indicates absent pleural sliding. And when you have pneumothorax, you don't have sliding. But the most specific sign of pneumothorax is actually seeing a lung point, which means you see the junction between the normal lung and the non-sliding lung. So this part here is sliding, right? And this part here is not sliding. So the junction between non-sliding lung and the normal sliding lung is called lung point. And that is a more specific sign of pneumothorax. Here is another example. This part of the pleura is not at all moving or shimmering. And this part of the pleura is moving with respiration. And the junction is the lung point. And on M mode, you can see there is some grainy appearance here in the normal area, that is sandy beach. And here you have the barcode. Okay, and probably we don't see so much, pneumothorax in the nephrology practice, but it's always good to be aware, especially in a high hemodynamically unstable patient. You know what you're doing. You don't just attribute everything to volume overload. Okay, so what are these B lines now? normal lung, when it's filled with air, has A lines that are horizontal artifacts, and B lines are vertical artifacts. So how these things are formed? So this is the pleural line here, and there is parietal pleura and visceral pleura, and here there are interlobular septae, and in between there are the smaller airways and alveoli. So when interlobular septae thicken because of fluid accumulation, because of interstitial edema, then B lines are formed. So the model that is accepted for the formation of B lines is called a ring down artifact and a tetrahedron model. What that assumes is that, say here, so we are looking at this point here, right? So interlobular septum is thickened or has fluid here in the middle, and on either side it's surrounded by air bubbles, and air is refractive to ultrasound. So when you send the ultrasound beam here, the ultrasound beam just dances around in this water bubble in the middle because of the surrounding air, and each time it makes a trip within the fluid bubble, it forms a small horizontal line, and as multiple horizontal lines form, you ultimately have one long vertical line that is called the B line. So basically B lines follow interlobular septae. So that is the commonly accepted theory behind B lines. So this is called the ring down artifact. On ultrasound image, this is how B lines appear. So here is the pleura, and B lines always start at the pleura and go towards go till the end of the ultrasound image. That's very important, because if your depth is not adequate, sometimes you see some shimmering vertical lines starting at the pleura, but if they do not go to the end of the screen, they are not B lines. And also with breathing, B lines keep moving. So those two are important characteristics of B lines. And here is another example of B lines. And you're covering multiple intercostal spaces here. Here is pleural line, here is rib shadow, here is another rib shadow. So this is one space, this is one space, this is another space. And you have multiple B lines arising from the pleural line and going towards the end of the screen. In such cases, it's very hard to count B lines. Normally, if you want to count B lines, you can freeze the screen because they are continuously moving with respiration, and then measure one by one. And some newer machines have software in them which automatically counts the B lines. But regardless, it's not necessary that you do a 28-zone ultrasound and count B lines in real life, as long as you know that there are B lines. And the more the B lines, the bad is the congestion. You get a visual idea as you see more images. And
sorry to interrupt you. Actually, people are not able to see the pointer, I suppose. If you can put in the slideshow mode and a pointer, cursor is not seen, Abhilash.
Sorry.
Cursor
do you see a laser light now?
Now I can see. Yes, I will. Sorry to interrupt.
Okay. Oh, no problem. Thanks for letting me know. So, yeah, B lines are not specific for pulmonary edema. That's important to note. So we said that when there is when there is fluid accumulation here, you have B lines, right? You can also have that when you have interlobular septal thickening for whatever reason, which also can happen in lung fibrosis or lung contusion. Actually, this particular image was obtained from a patient with diffuse alveolar hemorrhage with ANCA vasculitis. And here you can see the pleural line is not really regular. It's thickened. It's not like just one single line. It's very ups and downs here and breaks within the pleural line, thickened pleural line. And B lines are arising from the pleural line. But these B lines are not because of pulmonary edema, because of the diffuse alveolar hemorrhage. And similarly, in fibrosis or in lung contusion, the other pointers are, first thing is that you need to take into consideration the clinical context itself. Are you dealing with a patient who came after missing hemodialysis or something like that, or receiving lots of IV fluids, or you are dealing with a patient who has known history of lung fibrosis or some glomerulonephritis with possible pulmonary renal syndrome or something like that. And then you look for how the B lines are distributed. And B lines can also be seen in pneumonia. So if it's a patchy pneumonia, or if it's a lung contusion in one part of the lung where you have trauma. So in that cases, B lines will only be there in one part where there is trauma or where there is insult, and rest of the lung zones might show A lines, which is kind of unusual pattern when you have so much fluid in the lung in case of pulmonary edema. Other thing is then you use the linear probe to take a closer look at the pleura, and then you can see this discontinuity in the pleural line pattern. So here, this is the same patient. I use a different machine and a linear probe to see this pleura. You can see several breaks within the pleural line. Here is another nice image. Pleural line is no longer a line, but it's a discontinued crazy pattern. And in the lines, when we are talking about discontinuous pleural line, you can also have bigger subpleural consolidations, right? And pneumonia is not always lobar pneumonia. You can have patchy spots of pneumonia. And this is a nice example obtained in a child. In children, it's very easy because you can use linear probe. You can see, you can go further deep into the lung. So this person is what they're doing is like they're taking the probe and just going down, like up to down, and scanning multiple intercostal spaces. And at one point, you see that there is a break in the pleural line here. These are all A lines. Now here there is a break in the pleural line, and here you see the consolidated lung. Lung appears like a liver tissue. So it appears like a torn paper, right? That's why it's called a shred sign. So yeah, especially in children, it's that's a good idea to just scan multiple intercostal spaces. You don't need to pay attention to 8 zones or 6 zones or anything like that. And even in adults, actually, it's much easier when you're evaluating for pneumonia. Okay, so that's about B lines. So important thing is B lines are vertical artifacts, ring down artifacts. They are not specific to pulmonary edema. And next, how does pleural effusion appear? And where do you look for pleural effusion? Pleural effusion accumulates in the dependent parts, right? And in the initial study I showed, we saw that the chest X-ray is also not that sensitive for pleural effusion, because in supine patients, we get just one view of the X-ray and the pleural effusion tends to go posteriorly. So the chest X-ray might not really give you accurate idea of how much pleural effusion is there. But with ultrasound, you can go into the dependent zones of the lung. So typically you go to the mid-axillary line somewhere, like like where you would expect to see the diaphragm. Or you can just aim to just see the liver or spleen on the left and look for the diaphragm, and above that should be lung area. So that's where you would go and fan the probe anteriorly and posteriorly. That's where you are expected to see the effusion. So in the lower part of the lung, at the junction of chest and abdomen. So this is how pleural effusion appears like. So this is the head end, this is feet, because you have the probe orientation marker here facing towards patient's head. And this is the right-sided pleural effusion. This thing here is the liver towards the feet. And this bright line over the liver is diaphragm. And remember, fluid is black on ultrasound. So whatever black thing you are seeing here above the diaphragm is pleural effusion. And if you pay attention to the right-sided picture, you can see that there are some shadows here. These shadows are coming from vertebral bodies. Normally, when lung is filled with air, because air is reflective to ultrasound, you do not see any vertebral shadows. But when the lung is filled with fluid, or when lung is consolidated, because the lung is permitting to ultrasound waves, your ultrasound waves will be able to go posteriorly and hit the vertebral bodies. And vertebral bodies are bones, obviously, so bones have shadowing. And so if you are able to see this spine above the diaphragm, that means there is some problem with the lung. So that is called spine sign. It's a nice, useful marker when your image quality is not that good. And you can also sometimes see this, not sometimes, actually very frequently you'll see this. Within the pleural effusion, you see something floating, which appears like a jellyfish or whale tail. That is the collapsed lung. When you have pleural effusion, there is some lung collapse or atelectasis of the lung that looks like a whale tail. It can take different shapes depending upon how much fluid is there. It can appear like a scorpion sting and several other shapes, but this is how it commonly appears. So this is a nice example where in a fluid overload, presumably fluid overload patient, we were doing a lung ultrasound. And here the probe position is actually left upper anterior, like somewhere here in the anterior zone. upper. So there you are not generally looking for pleural effusion, right? There you are looking for B lines or A lines. Pleural effusion is always in the lower zones. But here we see this kind of picture. You see this floating lung and all this black effusion. So which tells me that there is so much fluid till the upper part of the lung. And now you get a chest X-ray, it shows complete white out lung. So you really don't need chest X-ray for the most part. And radiation, a lot of radiation can be eliminated. Probably individual chest X-ray is not probably that much radiation, but getting the culture of getting daily chest X-rays in the ICUs have been abolished in several ICUs that use lung ultrasound. Okay, anyways, so basically plain fluid is black. And when you start to see some echogenicities in the pleural fluid, that means you're probably dealing with a complex pleural effusion. And echogenicities, you can see them as white spots, where you call it plankton sign, or you can see the septations and lobulations in the empyema. It's important to know this thing because you never know. You can have a dialysis patient who always has some pleural effusion, but if you find this kind of stuff, you might want to refer to the hospital so that it can be taken care of. And this is an example of lobar pneumonia. So when the whole lobe of the lung is consolidated, it appears very similar to that of your atelectatic lung, but you typically don't have so much pleural effusion surrounding that. There will be a little bit of pleural effusion. And also, do you see something white inside the consolidated lung? So white things on ultrasound must be like bone or fibrous structure or air, right? And in this context, what would be in the lung? So it must be air. And why is it moving? So the air in the lung is moving with each respiration. That's analogous to bronchogram, air bronchogram that you would see on a chest X-ray. So basically, within the consolidated lung tissue, you have these airways, and air is trapped in those small airways, and with each breath, that air is moving. That's dynamic air bronchogram of ultrasound. When you see dynamic air bronchograms, most likely you are dealing with a pneumonia. Sometimes when you have a little bit, say 50-50 pleural effusion and consolidated lung, there might be a little confusion. But if you do see dynamic air bronchograms, that's most likely pneumonia. But if that air doesn't move, maybe it's atelectatic lung, because in compressive atelectasis, the small airways are collapsed. So you might not see that moving air. So those are called static air bronchograms, but they're not specific to atelectasis. So you can see static air bronchograms are non-moving white dots in both atelectasis and pneumonia, while the moving white dots or dynamic air bronchograms occur in pneumonia. And beware of this mirror image artifact when you're close to the liver and spleen. So you have the liver here, you have diaphragm towards the head, and above the diaphragm, you actually see mirror image of the liver, because diaphragm acts as a mirror, especially when accompanied, when it's adjacent to the air-filled lung. So you find a mirror reflection of the liver, and that's not consolidation or anything like that. Two clues are that one thing is it appears exactly like that of liver. If you have a cyst in the liver or some small hemangioma or some lesion in the liver, you get those things also here. And you will not see spine sign. Remember, with either pleural effusion or consolidation, you are expected to see spine sign because ultrasound beam is penetrating and going and hitting the vertebrae. But if it's just a mirror artifact and lung is still filled with air, you do not see the spine sign. So those are the clues. And obviously you don't see any bronchograms in this thing. Okay, that's about lung ultrasound in brief in relation to fluid status assessment. So now let's quickly talk about the pump or the heart or focus, which is focused cardiac ultrasound. As opposed to formal echocardiogram, focused cardiac ultrasound allows you to answer certain clinical questions. Answering those will give you some idea about the overall hemodynamic status. And the important thing to remember is when you start doing cardiac ultrasound, pay attention to what preset you are in. Generally, when you turn on the cardiac preset, the screen indicator changes. So when you're in the abdomen preset, your screen indicator is on the left side of the image. So if during abdominal scans, if you're you're holding the probe in such a way that the probe marker is towards patient's head. This is towards head, this is towards feet. But in cardiac preset, that screen indicator is towards right of the screen. So whenever we are holding the probe, when I say hold the probe towards right shoulder or left shoulder, I'm assuming that you are in your cardiac preset. Yeah, that's important to know because otherwise the image gets inverted. You can always analyze. It doesn't really make in terms of image interpretation if the heart is this way or if it's flipped to the other side. But when you're beginning to do the scans, it can get confusing. And there is really no science behind that. It's just that echocardiography was developed by cardiologists, so they used a different convention as opposed to radiology and OBG, who developed the rest of the ultrasound. So as mentioned in the last talk, these are the 5 E's of focused cardiac ultrasound. First, we want to know if there is any pericardial effusion, and we want to know how is the ejection. And third is equality. That means we are looking at the relative chamber size. Next is entrance, that is inferior vena cava, to assess the right atrial pressure. And finally, the exit. Exit in emergency medicine literature is primarily used to see if the aortic root is dilated in the context of a hemodynamically unstable patient. For nephrology purpose, you can also think of exit as measuring the stroke volume at the left ventricular outflow tract. And these are the basic cardiac views. And so these are 4 different cardiac views and 3 windows. And views and windows are commonly used, like interchangeably used. But in general, when you are saying window, it means that that's one rib interspace or intercostal space that you're looking at an organ from. And view is the view of the organ, like how you are slicing the organ. Okay, so the first view is parasternal long axis view. As the name says, it's parasternal. That means your probe is located adjacent to the sternum. And obviously, heart is on the left, so it must be left parasternal area. And long axis means you're slicing the heart in its long axis, not body's long axis, but heart's long axis, which is oblique. And parasternal short axis that means your probe is located parasternally and you're slicing the heart in its short axis or transverse plane. And apical 4-chamber view, that means you will go to the place where you expect to see the apical impulse of the heart, and you are slicing the heart in its coronal plane. So there you will see all the 4 chambers. And the last view is the subcostal view. Subcostal view or subxiphoid view. So your probe is in the subxiphoid area, and you are looking at the heart from the abdomen, or actually through the liver. Okay, let's take a closer look. You can also compare this as slicing a bread roll or a bun. Right? So if your heart is a bun, if you slice the heart like this in its long axis, like this one, this becomes the parasternal long axis view. And if you slice the bun horizontally, that becomes the parasternal short axis view. On the other hand, if you slice the bun in half from the middle, that becomes the apical 4-chamber view in its coronal plane. So yeah, this is basically the bun analogy of the heart, and that helps you to understand the views. And if you don't understand the cardiac views, or if you are unable to identify the cardiac chambers, the rest of the assessment is pretty useless. So yeah, we need to understand this. So let's go over each view. So this is a parasternal long axis view. As I said, you are slicing the heart in its long axis. So now look in this body here. So this is the long axis of the body, this vertical thing. But the long axis of the heart is this. So heart apex is here. So this is obliquely located. That's why your probe should be located towards right shoulder. So this is the right shoulder here. So your probe should be located towards right shoulder, somewhere here in the second or third intercostal space. Then you get this view. So remember, structures that are closer to the heart are on the top of the image. So right ventricle and left ventricle are not exactly side by side in the heart. Right ventricle has a weird shape. It actually wraps around the left ventricle. So you have the right ventricular outflow tract here, which is coming into contact with the ultrasound beam first. So on top of the image, whatever chamber we are seeing must be right ventricular outflow tract. And below that, or posterior to that is the left ventricle. And a chamber that is opening into the left ventricle must be left atrium. And the wall between left atrium and left ventricle is mitral wall. And where the left ventricle is opening into must be aorta. Obviously, aorta is towards the right shoulder, and here is the screen indicator. So we are saying put the probe orientation marker towards the right shoulder. So whatever is towards this part of the screen must be towards the right shoulder, and this is towards left hip. So that's all. You got your parasternal long axis view. So that's right ventricular outflow tract here, left ventricle, left atrium, and aorta. And you see the aortic wall here. So another way of looking at it. So if you're familiar with the cardiac MRI, or cardiac MRI is a good way to look at it. It gives you a sagittal section of the body, right? This is not exactly long axis of the heart, but still a sagittal view of the heart. So here is the anterior chest wall. Your probe is here. You're looking at the heart from here. So first, you're looking at the right ventricular outflow tract, and then here is the left ventricle. Here is the left atrium, aortic root, and a transverse section of the descending aorta will be seen posteriorly. So this is anterior here. This is posterior. So anterior here, posterior here. Okay, so I hope we oriented ourselves well to parasternal long axis view now. And remember that right ventricular outflow tract, aorta, and left atrium occupy roughly 1/3 of the plaques image or parasternal long axis image. That's why these are called three musketeers of the plaques view. The importance of knowing that is when an individual chamber enlarges a lot, you get a basic sense that you have chamber enlargement. So for example, when the right-sided pressure is elevated, your right ventricular outflow tract will be significantly bigger compared to rest of the two chapters. Or when you have aortic aneurysm, that will be big. Or when you have chronically elevated left ventricular filling pressures, or that is diastolic dysfunction, or mitral stenosis, you have a big LA. So all these things, you'll be able to get some idea if you pay attention to the three musketeers rule. And the next view is the parasternal short axis. So from the parasternal long axis position, where you are holding your probe with the marker towards right shoulder, you turn the probe counterclockwise. Now, you turn the probe or rotate the probe in such a way that your probe marker is towards left shoulder. So then you will see the heart in its short axis. So this is the probe orientation marker is towards left shoulder. So here is the screen indicator. So that means this is towards left shoulder, this is towards right hip. And this is how heart appears in its short axis. So you see a nice round left ventricle and a semilunar right ventricle. So here is a left ventricle, here is the right ventricle. And these things here are papillary muscles. And there are multiple views in this parasternal short axis. If you pan your probe inferiorly, you will find papillary muscles. If you're in the midway, you find mitral wall. And if you fan the probe further up, you'll find aortic wall. But in general, the view where you see papillary muscles is the standard transverse view for the POCUS purposes. And apical four-chamber view. So like I said before, you go to the place where you would normally feel for the apical impulse, somewhere in the fourth or fifth intercostal space, and look up. Then you will slice the heart in its coronal plane. And this is how it appears like. So the chambers that are closer to the probe must be ventricles, right? So the apex is comprised of ventricles, and then you have atria. And your probe orientation marker is towards left. So except for the parasternal long axis view, rest of the probe orientation marker for the rest of the views is towards left shoulder. For only PLAX view, it's towards right shoulder. So whatever chambers are on this side of the image must be left-sided chambers. So this is left ventricle, left atrium, mitral wall, right ventricle, right atrium, and tricuspid wall. Normally, the right ventricle is about 1/3 of the image, and left ventricle is about 2/3. That's important to note when there is chamber enlargement. And there is apical 5-chamber view also. So from apical 4-chamber view, if you fan the probe slightly anteriorly, you get a apical 5-chamber view. 5th chamber is nothing but the left ventricular outflow tract. It's same as apical four-chamber view, LV, LA, RV, RA, and in the middle, you have this left ventricular outflow tract. This view you use when you want to measure the stroke volume. And finally, the subcostal four-chamber or subxiphoid four-chamber. So in this, you're looking at the heart from the abdomen, or you're looking at the heart through the liver. Liver provides a window to look at the heart. So that means structure that is closer to your probe is liver. So liver is on top of the image. Whenever you see liver on top of the image and heart posteriorly, you are in the subxiphoid window. It's very similar to apical four-chamber, but it's just slightly tilted because of your angle. And chambers close to the liver must be right-sided chambers. And this is RA, RV, LA, LV. You don't see cardiac apex here typically in the subcostal view, though with some slight probe manipulation you might be. But in general, you are not expected to see cardiac apex. So when you are not able to get any thoracic views, this is a great view to look for pericardial effusion or any major lesions. Okay, in the subcostal view, you can also get the inferior vena cava. So once you get the subcostal four-chamber view with the probe marker towards patient's left side, then you rotate the probe such that your probe orientation marker is towards the patient's head. So this is towards head, this is towards feet. Now you get an inferior vena cava view. You can see this tubular, anechoic, or black structure entering the right atrium. And remember that IVC should pass through the liver. So you have liver tissue above and below IVC, and hepatic vein joins the inferior vena cava, and inferior vena cava joins the right atrium, or you just see a beating structure on the right, which is the right atrium. So it's important to note this thing because sometimes aorta, which is another tubular structure, can be confused for inferior vena cava. So this is the CT analog. So here is the inferior vena cava. You have the liver here, so it passes through the liver. You have the hepatic vein joining the IVC, and the IVC is joining the heart. So here is the ultrasound analog of that. IVC, right atrium, and hepatic vein. And it's important to note that most of the data, whenever we talk about IVC and right atrial pressure, the literature describes IVC in its long axis. But IVC is a three-dimensional structure, and we are using a two-dimensional modality, that is ultrasound, to look at the IVC. So it's quite possible that your ultrasound beam is passing like that is in the middle of your IVC cross-section, in which case you get accurate measurement of the diameter of the IVC. Or it's also possible that the ultrasound beam is slicing towards the side of the vessel, in which case you will get a falsely low diameter. And so to avoid that cylinder effect, it's always a good idea to see IVC both in long axis and short axis. In short axis, if you just rotate the probe 90 degrees, then you'll see IVC in the short axis. And here is the vertebral shadow here. And here is the aorta, the circular thing, towards the left, and IVC is towards the right. IVC is usually more elliptical compared to aorta, which is round. But when IVC is becoming round and round, that means it's becoming bigger and engorged with fluid. So in this case, IVC has become big. And in this case, IVC is small, elliptical, and collapsing. It's a normal right atrial pressure. In this case, there is elevated right atrial pressure where IVC is big and it's starting to become round. Oh, actually, in this image, if you pay close attention, you can see that so this is the anteroposterior diameter, right? So in longitudinal axis, we measure the anteroposterior diameter, but it's not always that IVC collapses only in the anteroposterior direction. And this IVC is actually collapsing sideways. So if you're just depending upon the long axis of the IVC, you might miss such kind of things when you're relying on collapsibility of IVC. So, okay, so that's about basic views of the heart. So we looked at parasternal long axis view, where your probe orientation marker is towards right shoulder, and rest of the views, parasternal short axis, apical four-chamber, subxiphoid four-chamber, and subxiphoid inferior vena cava view. So let's look at your 5 V's now. So first one is ejection. How do we know if the ejection is good or not? So let's look at the parasternal long axis view. When the heart is beating fine, that is normal ejection fraction. One thing is that the left ventricular walls should come close to each other by at least 25%. that's normal ejection. So normally it's about 25 to 50%, say. But at least if they come close to each other by 1/4, that's considered normal. And also, the mitral valve should open completely. That's because if the ventricle is contracting well, and at the time of relaxation, it will fill nicely, because that means more blood is going from left atrium to left ventricle during diastole. And when more blood is going, your mitral valve needs to open fully. That's the concept behind that. So mitral valve opens fully and gets almost close to the septal wall of the left ventricle in normal ejection fraction. And as the ejection fraction reduces, your valve squeeze reduces. It becomes less than 1/4, and the mitral valve does not open fully. And when your ejection is too bad, the ventricular valves barely move and mitral valve barely opens. So you're looking at two things: ventricular valves and mitral valve. So basically, the first image is normal left ventricular ejection fraction, second image is moderately reduced, and third image is severely reduced. Remember, we are not exactly measuring the ejection fraction here. This is the eyeballing method. It's a quick, dirty way of getting a sense of person's global cardiac function. If you need some semi-quantitative data, you can also use M mode and measure some things. So this is the parasternal short axis view. You turn on the motion mode or the M mode. So now it gives you like how your left ventricle is contracting over a period of time. And then you can see like what is the diameter in systole and what is the diameter in diastole. And then you can calculate by how much percent the left ventricle is contracting. Remember we said like about ventricle should contract by about 25 to 50%, right? So that's called fractional shortening. That is big number minus small number divided by big number. The normal is about 28 to 46%. That gives a better idea more than eyeballing. Here is an example of fractional shortening of the left ventricle. Here, fractional shortening is 34%, which is good. And the properly measured ejection fraction was 65, which is normal. And here, fractional shortening is about 8%, which is very low. And formally measured ejection fraction was 16%, which was also very low. And differentiate between fractional shortening and ejection fraction. These are not the same. It's just a fractional shortening is just a measure of by how much your walls are getting close to each other. And another parameter using M mode, you can do that using parasternal long axis view, is called EPSS. EPSS is E-point septal separation. What it means is you turn on the motion mode, you get your cursor and put at mitral valve tips. So because we said mitral valve should fully open when you have normal ejection fraction, right? So if it is not fully opening, that will tell you that heart is not functioning well. So during diastole, when the mitral valve is opening, there are two distinct waves. So this is the anterior mitral valve leaflet trace over a period of time, over various cardiac cycles. So in diastole here, you have two distinct movements of the mitral valve. The first one is E wave and the second one is A wave. So during diastole, when there is ventricular suction, initially, there is a lot of blood going into the LV, that is the E wave. And at the end of the diastole, there is atrial kick, pushing some blood into the LV, that is A wave. So normally, during E wave, the ventricular, the anterior mitral valve leaflet should almost touch the septum, or less than 0.7 is considered to be okay. That is less than 0.7 centimeter difference between septum and the highest point of the E wave. That is the E-point septal separation, EPSS. Generally, more than 0.8 is considered to be significantly reduced ejection fraction. So both fractional shortening of the left ventricle and EPSS give a semi-quantitative idea of how your ejection fraction is. And next, pericardial effusion. Any effusion should be black, like pleural effusion is black, pericardial effusion is also black. It's just that it surrounds the heart. So this is a parasternal long axis view of the heart. And you have this black structure here, which is the pericardial effusion. Here is another example of pericardial effusion. And here is the aorta. Yeah, and unless it's complex effusion, it's black in color. And yeah, so depending upon how much separation is there in between these two pericardial layers in diastole, we can get a semi-quantitative idea of the effusion. And we have to measure that only in diastole, not during systole, because in systole, the ventricle is contracting and your space will anyways increase. So during diastole, if this black layer or the separation between pericardial layers is more than 2 centimeters, that's severe pericardial effusion. Less than 1 centimeter is mild effusion, and 1 to 2 is moderate effusion. That gives some idea of severity of effusion. And this is a nice 4-chamber view of the heart surrounded by pericardial effusion. Here you see that heart is swinging in pericardial effusion, giving you the pulses alternance on EKG. And here is another example of pericardial effusion seen on subcostal 4-chamber view. So here is the heart and surrounded by pericardial effusion. And just by looking at this inferior vena cava view, you can note that there is pericardial effusion here, because here is the IVC, here is the right atrium, here is the beating structure, that is the heart, but there is a gap between the beating structure and the liver, which must be pericardial effusion. So even if you're just looking at the IVC, pay attention. If you find something suspicious, always evaluate the heart. So what do we see in this image? So it appears like a parasternal long axis view of the heart. And you see some black structure here. You see another black structure here. So what are these things? So when we look at the thoracic cavity, and your probe is here, and you are imaging the heart like this. So this is like a tilted parasternal long axis view of the heart. Here is the RV, LV, LA. Your probe is here. So as you go more posterior, that means you increase the depth of the ultrasound screen, you see more posterior structures. What is posterior to the heart here? You have left lung. So if there is a pleural effusion in the left lung, you'll be able to see it here. A good landmark is descending aorta. Remember, you see descending aorta cross section in the parasternal long axis view. So if there is a pericardial effusion, it should always start anterior to the descending aorta. And if there is pleural effusion, it is usually at the level of descending aorta or posterior to that, and follows the curvature of the chest wall. So this is a very important and interesting landmark. Okay, so now go back to your original picture. So this is the parasternal long axis view. Here is the aorta cross section. So anterior to the aorta, starting like a wedge here, is a pericardial effusion. It's small. On the left, you can see the scale. It's definitely less than 1 centimeter. It's a small effusion. Here is this black thing here is the left pleural effusion. And inside, you can see some atelectatic lung. And it often provides a clue. I hope you are not running out of time, right?
No, Abhilash, you can please go ahead.
Okay. So, yeah, this is another nice example here. So left pleural, another example of left pleural effusion. So in this case, there is no pericardial effusion, but here is the aorta and here is the left pleural effusion. So that's why it's important to pay attention to the curvature of chest wall. Even if you don't see atelectatic lung, pleural effusion follows the curvature of the chest wall. So this is what we are seeing here. Here is the heart, here is descending aorta, here is the left lung area and effusion here. So the third thing is the equality. That means we are comparing the chamber sizes. So this is typically done in parasternal short axis view and apical 4-chamber view. In parasternal short axis view, left ventricle is normally supposed to be nice and round, and right ventricle is semilunar. But here in this image, you see that left ventricle is not round, and RV seems to be too big, and there is flattening of the interventricular septum. That indicates that the RV has enlarged a lot and it's compressing on the left ventricle. Now, so this, because of this interventricular septal flattening, the left ventricle becomes a D-shaped instead of normal circular shape. And if you give more fluids to this patient, the fluid is going to the right side of the heart, and it's going to compress the left ventricle, further reducing the stroke volume and potentiating the shock state. So equality is best assessed in the parasternal short axis view. And in general, this D sign, you see more pronounced D sign in diastole when there is primarily volume overload, because right ventricle is filling during diastole. And when you have more volume in that, it distends and creates this D sign in diastole. And when you have more pressure overload, as in pulmonary embolism, right ventricle is struggling to beat against pressure, that's when this D sign occurs more in systole. I mean, most of the time, these two things can occur simultaneously. But if you are able to differentiate, that gives some clue. And here is apical 4-chamber view, allowing you to look at the chamber equality. Normally, we said that the right ventricle should occupy about 1/3 and left ventricle about 2/3. But in this image, RV is easily, it's obviously bigger than the LV. So this is severe enlargement of the right ventricle as seen on the apical 4-chamber view. Generally, LV is bigger than RV. If RV is slightly more than 1/3, it's mildly enlarged. If RV is same size as that of LV in apical 4-chamber view, that's moderately enlarged. And if RV is more than that of LV, you can consider that as severely enlarged RV. And in this image, of course, RV is bigger than LV. So there is definitely increased right-sided pressure, but there is something else going on here. What is this? So here at the apex of the right ventricle, you see there is some winking of the right ventricle. And that's called McConnell sign. And McConnell sign is relatively specific for pulmonary embolism in the right clinical context. I mean, it can also be seen in very severe chronic pulmonary hypertension, but in general, when a patient acutely becomes hypotensive and you see this sign, most likely you're dealing with pulmonary embolism. What's happening is because of the pressure overload, initially the RV is dilated and its systolic function reduces significantly. And its contraction mainly depends upon the left ventricular pull. So left ventricular fibers extend till here and they keep pulling the RV. So rest of the RV is not contracting as much, but here because of the left ventricular pull, it appears as if the apex of the RV is winking. That's McConnell sign. And another thing to look for it is not about volume, but in general, when you're doing your right, anyways, getting a apical 4-chamber view, say if you put a dialysis catheter, and normally you would wait for a chest X-ray to start doing CVVH, right, or dialysis or continuous venous hemofiltration, whatever. So instead of waiting for chest X-ray, if you just want to start dialysis, you can do, as long as you know that whatever you're giving through or removing using that catheter is from the right atrium. And how do we know that? You just put the catheter and inject an agitated saline, and it opacifies the right atrium like this. That means your catheter is in the right place. Whether it's exactly at the tip of the right atrial SVC junction or slightly lower, then you can do X-ray at a later time. But for immediate purposes, if you see this thing, you can start using your line. So that is called rapid atrial swirl sign. So by giving agitated saline, we are opacifying the right atrium. So next is the entrance or IVC. So IVC is entering the heart, and like I said, it's just a tube that is reflecting the pressure changes in the right atrium. And so how do we estimate the right atrial pressure using inferior vena cava? Normally, if inferior vena cava is less than 2.1 centimeter in its widest diameter, generally we are talking about anteroposterior diameter, and more than 50% collapsible during inspiration, we consider that as a normal right atrial pressure. For the sake of putting a number, we put 3 millimeters mercury in the note. And if the IVC is bigger than 2.1 centimeters, that is dilated, and collapsing less than 50% in inspiration, then you consider high right atrial pressure. For the number, you take average of 15 millimeters mercury of CVP. And in between, if it's less than 2.1 centimeters, but collapsing more than 50%, or more than 2.1 centimeters, but collapsing more than 50%, then you assign an intermediate value to the right atrial pressure, which is 8 millimeters mercury. This is a rough estimate in spontaneously breathing patients, because in spontaneously breathing patients, right atrial pressure should decrease during inspiration and venous retention should increase. So that's when inferior vena cava collapses. And these numbers are not applicable in mechanically ventilated patients because the patient is not typically spontaneously breathing. Even if the patient is spontaneously breathing, it becomes erratic because when the patient might be breathing with the vent or without the vent, and the degree of the respiratory effort may vary. So it becomes tricky. So you don't assign these numbers in ventilated patients. So typically what you do is if you see echo reports in all mechanically ventilated patients, they just report one number, that is 8 millimeters mercury. It doesn't mean anything. So next time when you see echo reports, you can note that there will be no other number for right atrial pressure in the echo. It's only 8 millimeters mercury. And so what's the purpose of looking at getting an idea of right atrial pressure is that if the right atrial pressure is high, you don't want to give fluids, because right atrial pressure essentially is a marker of resistance to venous rhythm. When there is more resistance, why should we give fluids, right? Probably such patients won't benefit from intravenous fluids. So IVC should be used as a stop point and not a tool to give fluids. If the IVC is small, so if the IVC is 1.8 centimeters and collapsing more than 50%, that could be completely normal. The patient could be euvolemic. That does not tell you if the patient needs fluids or not. That's a very important thing to note. Because our normal right atrial pressure is somewhere between 0 and 5, right? 0 can be normal right atrial pressure too, but only in the right clinical context. If you're dealing with a patient with history suggestive of hypovolemia, and then you see a small IVC 1.2 centimeter and it's completely collapsing, then it supports your idea of giving fluids. But in general, it could be normal too. And it's generally not preferable to use IVC ultrasound to assess fluid responsiveness also, because fluid responsiveness, when you're talking about it, it's increase in the cardiac output or stroke volume in response to your preload. And we are just looking at a tube that is going into the right atrium and trying to guess what is responsiveness. As opposed to that, you would just want to measure the stroke volume yourself and give fluid or raise the patient's legs so that about 400 cc of fluid goes into the heart and see if the stroke volume is increasing, but not this. This is very much error prone. And also we need to think like, why should we even assess for fluid responsiveness, right? So if the patient requires fluid or does not require fluid for the most part. So if the right atrial pressure is significantly high, probably you don't need to assess fluid responsiveness. Typically, we need to assess fluid responsiveness when there is some disagreement between two physicians and the IVC pressures are somewhere in the intermediate range, and one person wants to give fluids, one person doesn't want to give fluids, and then if anyways you are leaning towards giving fluids, then it's better that you make sure the patient is actually responsive to fluids before administering them. So IVC, so this is the small IVC I was talking about. If the patient has history suggestive of volume depletion, you are strongly suspecting hypovolemic hyponatremia, and you find this kind of IVC here, you barely see any vessel, right? Except, see here, in respiration, inspiration, it's completely collapsing. You don't see any vessel. During expiration, you barely see that hair-like IVC. So that's very small and collapsible IVC. If you see that, probably that's most likely volume depletion. And this is a plethoric IVC here. It's much more than 2 centimeters and not at all collapsing with respiration, inspiration. And here is the IVC cross section. This IVC appears like a slit, and this is the aorta here. Aorta is nice and round. This IVC is like a slit and small. That could be normal or volume depletion. While this IVC here is so big, and here is the aorta actually. This IVC is like round and so like much bigger than the aorta. That tells that this IVC is full, and giving fluids to this patient might cause significant harm. And that patient can be hypotensive too, right? So we will see further examples. So left ventricular outflow tract is the exit. I'm not talking about Doppler applications today, but in general, it gives you a general sense that you use the pulsed wave Doppler, which is the Doppler that you get blood flows. You put that in the left ventricular outflow tract, just proximal to the aortic wall, and you get a trace like this. So with each beat, you have this blood ejection. That's the stroke volume. And there are certain calculations you can do to that measurement and calculate the stroke volume. So we'll leave it alone for now. So how do we put all these things together, right? So we know that hypotensive patient, it's not necessarily shock, but hypotension can have all these etiologies similar to shock. So you can have hypovolemic shock where the problem is volume depletion, or cardiogenic shock where there is pump failure, or obstructive shock where the pump is okay, but something is not letting it work. So it could be pericardial effusion or pulmonary embolism causing that obstruction, or it could be distributive shock where pump is fine and it is actually working a lot, but the cause for hypotension is the decrease in peripheral vascular resistance. So what would you expect on focused cardiac ultrasound? If it's hypovolemic, heart is beating hyperdynamically in an attempt to generate adequate cardiac output. So the stroke volume is reduced, but the heart rate and heart contractility will be increased. And IVC is typically small and collapsible. In cardiogenic shock, there is decreased LV function. You can eyeball, you can look at E-point septal separation, you can look at fractional shortening, whatever that is, you'll find decreased LV function, decreased cardiac output, and a dilated IVC because the right atrial pressure is high. That's cardiogenic cause of hypotension. And in obstructive causes, you can see a pericardial effusion, or if you're dealing with pulmonary embolism, you can see a dilated right ventricle, and maybe McConnell sign if it's severe, and maybe decreased cardiac output, and decreased cardiac output if you measure it, causing hypotension. And IVC is typically dilated because of elevated right atrial pressure in these obstructive causes. And in distributive shock, this is tricky. This is basically the example is septic shock or liver cirrhosis patients at baseline. They have hyperdynamic heart pumping out a lot of blood. So stroke volume is increased, the cardiac output is increased, and because the heart is hyperfunctioning because there is splanchnic vasodilatation or peripheral vasodilatation. But when the heart tires out, when there is septic cardiomyopathy or when there is cirrhotic cardiomyopathy, then you can have decreased LV function, and the findings can look similar to cardiogenic picture. Or IVC is also variable. Say initially the septic shock patient might be, or a septic patient, not necessarily shock, might be volume depleted because of the fever and infection. In that case, IVC might be small, but as you resuscitate the patient and you over-resuscitate the patient, by the time nephrologist sees, IVC can be big because of fluid overload. And similarly, in volume depletion, lungs typically have A lines. In cardiogenic causes, you see B lines and maybe pleural effusions. And in obstructive causes, most likely you will see A lines. Rarely you might see focal B lines when you see pulmonary infarction as a subpleural consolidation, and there are some B lines surrounding that area, but they are typically focal only at the places of pulmonary infarction, but rest of the lung is expected to have A lines. And in distributive shock, in sepsis, you can have anything. You can have A lines or focal B lines, especially if you're dealing with a consolidation as a cause for your sepsis. Last few slides are some examples. So if you have a combination of these things, what do you think? So first, this is heart, and we are looking at the M mode, EPSS. So this is the mitral valve tracing, and here is the E wave, A wave, and the distance between E point, or the highest point of the E wave, and the interventricular septum is 2.5 centimeters. So that's very significantly elevated, right? Normally we said it should be less than 0.7 centimeters. It's very significantly elevated that this patient has bad cardiac failure. You don't even need to see heart in action. Just by looking at this picture, you know that it's bad CHF. And IVC here. This IVC is big and plethoric. On the left side scale, you can see that it's at least 3 centimeters in its widest diameter, and it's barely collapsing. These things here are dilated hepatic veins. So this appears like a face, like a liver face with these two eyes, which are hepatic veins, and a big mouth. So basically, liver is screaming, no more fluids. And lung is showing B lines here. You see the pleural line, and vertical artifacts are arising from the B line. And this patient, hypotension is most likely cardiogenic in origin. And here is another example where you see, here is the EPSS, and this patient was also tachycardic. So you can see that there is essentially no distance between E point and the septum. So EPSS is virtually 0. That means this is a hyperdynamic heart. And IVC is small and collapsible. It's very small. It's about 1 centimeter. And lungs are showing A lines. In the right clinical context, this is more likely to be hypovolemic origin of hypotension, or it could be sepsis also. You can have hyperdynamic heart and sepsis also. The only way you can differentiate it well is by measuring the stroke volume. And here is a nice example of D-shaped left ventricle or significantly dilated right ventricle. Here's a parasternal short axis view in a patient with pulmonary hypertension. So here's the dilated right ventricle. There is interventricular septal flattening and D-shaped left ventricle. And in the apical four-chamber view, you see a dilated RV pushing the left ventricle. So the cardiac output will be reduced if you give fluids to this patient. And this IVC is horribly enlarged. And it's not always that dramatic, the D sign. So this is an image obtained from a patient patient who had liver cirrhosis getting blind albumin therapy, empiric therapy based on guidelines. So now we look at the heart. Now you can see that there is some emerging D sign, right? So if you pause the image and look at it carefully, so you can see that during systole, when the ventricle is contracting, you see it's more or less round like this, like there is not much of a D sign. But when the ventricle is relaxing, the ventricular, interventricular septal flattening starts to appear. So that is, remember, like in diastole, if the flattening is occurring, it's most likely suggestive of fluid overload. So this patient would not benefit from this blind empiric albumin therapy, and you should stop it. And we followed up after stopping albumin therapy, and now the left ventricle is round in both systole and diastole. So not only a combined assessment, but also individual components will help you. And ESRD patient with missed hemodialysis, the IVC is big. So you just say, okay, let's pull some fluid. But if you carefully look at this, there is some anechoic area in between liver and the beating structure, that is the heart. So there must be pericardial effusion. So if you pull a lot of fluid from this patient, what happens? You will decrease the intracardiac pressures during dialysis, so that your extracardiac pressure, or the pressure from the pericardial effusion, is increased, and it's going to cause tamponade physiology during dialysis. So we have to be very careful. So these are the cardiac images from the same patient. So, you know, left ventricle appears very thick, right, which is a common finding in dialysis patients. But here is the pericardial effusion. And in diastole, the separation is close to 2 centimeters, which is kind of severe pericardial effusion. And here is another example of pericardial effusion. This effusion itself doesn't seem to be too bad, right? So here is a scale on the right side, and each gap is about 2.5 centimeters. It's maybe about centimeter or slightly more than that, not too bad. But you see this right atrium here, it seems to be collapsing, right? I mean, collapse of right atrium in diastole is like a sign of tamponade. I mean, you have to assess carefully whether it's systole or diastole, but you know that there is some pressure effect on right atrium. But the IVC is not big. In tamponade physiology, you typically expect that IVC is plethoric, right? That's what we said that in the chart. And you confirm that in the short axis also. It seems to be slit-like. But why is there pressure effect? So this patient with pericardial effusion was volume depleted. So volume depletion and pericardial effusion is not a good combination. So it's same thing as removing more fluid during dialysis, right? If you're volume depleted, your pressure inside the heart is lower. And even if the pericardial effusion itself is not large, it can cause tamponade physiology. So you need to pay attention to IVC also. So you have to assess both IVC and the heart. And this is the last example here. Another nice example of in this parasternal long axis view, out of the 3 musketeers, RVOT, aorta, and left atrium, the RVOT is enlarged significantly. You see the same thing in the apical 4-chamber view. RV is so big and pushing on the LV. And here you have big RV, but what's happening in the lung? You see B lines, but it does not necessarily mean it's water. Remember, we said in pulmonary fibrosis also you can have B lines. So this patient had severe pulmonary fibrosis and consequent right heart failure. So finally, it's all about interpreting in the right clinical context. And this machine does not interpret for you. And you use your own brain and interpret everything in the clinical context. Thank you so much.
Thank you, Dr. Abhilash. It's a wonderful presentation. Thoroughly enjoyed it. You have literally given us a third eye to look at the patient in a completely new paradigm shift in a way for me. There are a few questions in the chat box, but before that, I just would like to ask you a quick one. So the most common clinical conundrum I face in patients with ICU is differentiating patients who are intravascularly volume depleted, but have got quite a lot of peripheral edema. I'm sure all the ultrasound techniques are meant to assess intravascular volume. Is there anything where you would know that there is also extravascular volume overload in these patients and may or may not be affecting the intravascular volume status? And sometimes it is a clinical decision-wise, it is extremely difficult, especially in patients who are obese and quite big. I would like to know your sort of experience and any input or pointers in understanding the volume status.
If I understood the question correctly, we are trying to differentiate between intravascular and extravascular status. So in general, if the patient is intravascularly depleted, that means your IVC is small and the heart is hyperdynamic and the stroke volume is low, no matter what's the extravascular status, even if the patient has swelling in the feet or like mild pleural effusion or ascites, you're not going to give diuretics, right? Because diuretics are anyways going to harm the patient who already has low stroke volume. And the extravascular expansion is probably because of increased permeability in the case of sepsis or low albumin states and so on. So yeah, I think like if you're depleted intravascularly or depleted, you need to, you cannot give diuretics because you will cause organ injury. So basically you take into consideration your how the kidney function is doing with diuretics and ultrasound, and you need to do this assessment on a daily basis, right? And the patient's situation change on a day-to-day basis or even on an hourly basis in ICUs. So I don't know if that answers your question exactly, but that's what I understood. Like if you're depleted, you're depleted. Don't give diuretics. If you have too much fluid in the intravascular compartment, yes, give diuretics. Both these actions will help your kidney function. But if you have so much discordant thing, then you need to look at the overall clinical picture and decide on a day-to-day basis.
Sure. Okay, that's very good. Thank you. A few other questions here. So someone is asking about the influence of ventilatory support on IVC diameter in volume assessment.
So when somebody is on mechanical ventilation or positive pressure ventilation, the IVC is dilated at baseline, right? And instead of collapsing in inspiration in spontaneously breathing patients, during mechanical ventilation, it dilates during inspiration or the positive breath and collapses a little bit in expiration. So people looked at how much the IVC is expanding or looking at the distensibility index and try to predict fluid responsiveness. That's why I mentioned that specifically, that don't use IVC as a tool to predict fluid responsiveness. Just use IVC as a tool as the determinant of right atrial pressure. And like if the IVC is big, it's big, no matter why it is. Mechanical ventilation could be contributing, or many of the ICU patients also have right ventricular dysfunction. So right atrial pressure is already big, right? If the IVC is big and plethoric, don't give fluids and think of other etiologies. And if you're talking about fluid responsiveness, it's better done by assessing the stroke volume itself rather than just relying on IVC. There are parameters like distensibility index more than 12 or 18 might predict fluid responsiveness, but it's very much error prone. It becomes even more tricky when the patient is spontaneously breathing. It's actually said that to be able to accurately predict fluid responsiveness using inferior vena cava, the patient has to be completely sedated and paralyzed, and only about 2 to 3% of ICU patients satisfy all the criteria you need to satisfy to assess volume responsiveness using IVC parameters. So I think it's practically useless. But yeah, in general, IVC is enlarged. And if you're looking for further downstream effects, you need to do Doppler assessment of the hepatic vein, portal vein, and see how the blood flow is. But in general, a bigger IVC is always increased right atrial pressure.
Sure. On the similar note, if the IVC is collapsing in a ventilatory patient, would that represent underfilled patient? So if it's small,
possibly yes, yeah, it's probably it's possibly we are talking about more inspiratory dilatation or expiratory collapse. Yes, in the right clinical context, if you want to give fluids, probably I wouldn't be opposed. Ideally, though, you want to check stroke volume, but I understand it might not always be possible. Your patient might not have good cardiac windows. You might not have invasive monitoring. That's fine. Yeah, if IVC is collapsing significantly collapsing, say 50% collapsing in a mechanically ventilated patients, I would think about volume depletion, especially if you find some hyperdynamic heart. Even so, that means if you are getting IVC, even if the chest window is difficult, you are getting still subcostal, right? So you can get subcostal 4-chamber view of the heart and get some global sense. Make sure there is no significant pericardial effusion and see how the heart is beating and then go from there. Yeah.
would you recommend sort of leg raising test before you inundate the patient with fluids in such patients, or would that help?
Yeah, if you want to assess fluid responsiveness, it's better to use passive leg raise. Like I said, you typically, I don't always do that. I don't always assess for fluid responsiveness because most of my work is about trying not to recommend fluids. So, but when there is still a disagreement between two people and one person definitely wants to give fluids and IVC is not like super plethoric, then you would do fluid responsiveness. Either you can do whatever fits, like either you give a small bolus of 500 cc normal saline, or you passively raise the legs. That way about 400 cc of blood is going into the heart from your legs. That is like auto transfusion. But passive leg raise actually is not that easy to do. It all depends upon your how your bed is actually like. If your bed allows you to do that, because most of the time what we do is like depending upon what buttons your hospital bed has, you just do the Trendelenburg position and do it. But actual passive leg raise is just lifting the legs and not the whole body. But yeah, but it still gives some idea. Even if you do the Trendelenburg position, it gives some idea as to if the stroke volume is increasing or not.
Sure. So a question from Dr. Manjusha. Is it possible to differentiate between cardiogenic and non-cardiogenic pulmonary edema with lung ultrasound?
It is to some extent. So the first thing is, like I said, there are other markers to note. When you have cardiogenic pulmonary edema, the first thing is suspicion. If the heart is not beating well and there is a diffuse B-line pattern in almost all the auscultation zones. But if that's not the case, and if you are seeing B-lines in only some areas, or even in one particular intercostal space, half of the pleural line has B-lines and half doesn't have, that also can happen. Those are called spared areas. That's a clue that probably it's not diffuse pulmonary edema. And also then you look at the pleural line using your linear probe. Look for pleural line irregularities. Then it's probably not, it's probably more related to like intrinsic lung pathology. So these are some signs. And when you can also see some local shred sign and local consolidation and associated B-lines. So these are the signs, but none of this is accurate. You can always argue that I can have lung fibrosis at baseline, but I can still develop pulmonary edema, right? So for that, you need to be able to do some Doppler applications. Then you go to the heart and assess left ventricular filling pressures. So in the initial Doppler picture I showed, like at the mitral wall, if you assess the flows, you will get some idea of how is the left ventricle filling. So if the left ventricular filling pressures are high, it's most likely cardiogenic. If the left ventricular filling pressures are not high, it's most likely lung-related pulmonary edema. So you need to, basic lung ultrasound helps to some extent within the overall clinical context. But if you have Doppler expertise, that helps more, that gives more information. But obviously, if the patient is so complex and in critically ill in the ICU, I would rather just do the right heart cath or swan dance.
Sure, thank you so much. This is a question from Dr. Krishnan. Can we use POCUS for pericardiocentesis, pleural tab, drain assist?
POCUS pericardiocentesis during what, sorry?
So he's asking if can we use this POCUS for pericardiocentesis or pleural tab or draining assist?
Oh yeah, absolutely. Yeah, that's procedural POCUS. Yes. Yeah, that's a very common practice, and you typically don't drain any of these things without POCUS assistance. So it's a very common practice to drain all these things.
Yeah. The next question from Dr. Manjusha. Can collapsibility be checked in other veins like IJV or femoral vein?
Yeah, you can check IJV in also. It's just that practically, I maybe more personally, I don't like IJV that much because most of the times, depending on the patient's position, the patients tend to have central lines, and apart from that, you tend to exert too much pressure with your probe inadvertently on the IJ vein. So it's very sensitive to your probe pressure. That's why I think IVC is much easier to do and more reliable than IJ. But yes, if you're able to get a reliable IJ, actually overall image acquisition is easy because the neck is right there. You can get a sense of what is the IJ vein diameter and assess collapsibility. Yeah.
Can I just ask a quick question here? So, I mean, traditionally we have used the central venous pressures and transducers connected to the central venous lines to let us know the right atrial pressures. And obviously visual sort of ultrasound is much better in understanding or trying to remove the artifacts. Say, for example, if we do not have access to an ultrasound straight away, and we have access to the central venous pressure transducer, I mean, would you use that in place of ultrasound?
Yeah, of course. Yeah, whatever is available. Yeah. Again, like use should always be dependent upon like what's your clinical question, right? So if my clinical question is whether right atrial pressure is elevated or not, so compared to yesterday, is it better or not? Yes, of course you can use central venous pressure, but only thing that we should not use it for is to assess fluid responsiveness. Fluid responsiveness is never assessed using a static parameter. So, or basically any measure of heart preload will not tell you preload responsiveness. So that's the difference. That's the difference most of us don't understand when we start doing POCUS, is that IVC is so interchangeably used, right? So I say IVC is for right atrial pressure, and most people come and say fluid responsiveness. That the problem happens even for my manuscript. Somebody is reviewing, the reviewer gives some strange references saying that you can use IVC in ventilated patients, but I'm talking about a different thing. So you never use IVP or CVP, which are static measures, to assess preload responsiveness, but they definitely give a good idea of the right atrial pressure. Yes.
So I just probably want to highlight the fact that elevated pressures do not always mean we don't give diuretics, because if you've got patients with right atrial, right ventricular pressures because of, let's say, pulmonary fibrosis or something, the treatment there tends to be diuretics to an extent. So I think we need to get that message across to the audience to say that don't give diuretics if the venous pressures are high. Tension, then even though the pressures are high, you may want to reduce the diuretics. So I think this is something that there is a discordance that we need to highlight, I guess.
Exactly, that's a great point. So yeah, so if the IVC is big, that does not always warrant diuretics. That's why you look at both right heart and left heart. Like you said, if it is reducing, and also, I mean, when not talking about critically ill patient, you can have a patient with chronic pulmonary hypertension, but also have volume depletion on right on pre-existing. That you can still have like a bigger IVC always. Having access to prior imaging helps, and if not, using Doppler ultrasound of the other veins will help, because if you look at portal vein is not a direct tributary of the IVC. So it is shielded off from the IVC or central pressure by hepatic sinusoids. So central venous pressure transmission is not linear to the portal vein. So if you look at the portal vein waveform, you get some sense as to like if it's normal or if it's abnormal. So if the portal vein is abnormal and very pulsatile, that might indicate that even a patient with pre-existing pulmonary hypertension is probably has further increase in right atrial pressure. So yeah, and even if you have chronic pulmonary hypertension, the portal vein pulsatility can normalize because the transmission of CVP is not linear. So yeah, we need to take into context multiple organ ultrasound. So single organ ultrasound always fails. POCUS is not a magic, and it's just an addition to overall clinical picture. The more POCUS applications you are familiar with, the better decisions you'll be able to make.
Okay, so there's another question from Dr. Shavia. Should we always use distensibility index in ventilated patients and not collapsibility index? I'm not familiar with the distensibility index. So if you can expand on that, if you know.
In general, it means the same thing actually. So you can say IVC collapse, but on the other hand, we say it's distensibility because during inspiration, IVC is expanding during in a mechanically ventilated patient. That's what we are talking about, distensibility instead of IVC collapsibility. So we are just keeping the phase of the respiration constant and just saying IVC collapsibility during inspiration and IVC distensibility during positive pressure ventilation. Yeah, I think I previously answered this, like if the IVC is more distendable or like moving more with respiration, and if you are suspecting volume depletion, it's fine to give fluids. But again, like the distensibility index specifically has come into use to assess fluid responsiveness, but it's very erratic. And like I mentioned multiple times, don't use IVC or distensible index to assess fluid responsiveness as much as possible.
Sure.
Yeah.
Question from Dr. Abish. Any specific site for measuring IVC diameter?
Generally, you measure like below the hepatic vein. So most important thing is where not to measure. Don't measure at IVC right atrial junction, because there is diaphragm, and diaphragm will exert pull on the IVC and you will have false collapse. So don't do there, but come down and go 1 centimeter below the hepatic vein IVC junction and measure it there. It's more of a convention, and there are several studies which looked at like which is the best site to measure, and they assess different parameters. So this is what we generally agree upon. So just 1 centimeter below the hepatic vein IVC junction.
Great, thank you. Next, the question from Dr. Raghu. Which position is better for POCUS of lungs, supine or propped or sitting position?
It's supine. So like remember those 8-zone ultrasound, like we are auscultating 4 zones. So like we are auscultating 2 anterior zones and 2 posterior, 2 lateral zones at least. So in most hospitalized patients, it's difficult to turn them like this way or that way, right? So they're just lying in the bed and you want to do that. But important thing is not to miss the lateral zones because that's where the dependent fluid is going to accumulate. So go to the lateral zones and aim the ultrasound beam little posteriorly and look for any effusions and B lines in the dependent regions. As long as you make sure that you auscultate lateral zones, that's okay. You don't need to turn the patient. Only exception is like if you're suspecting multilobar pneumonia or atypical pneumonia, then you want to make sure that you auscultate posterior zones also. Or in prone patients in ARDS, in those patients, you can monitor the posterior lung zones for recruitment and improvement in ARDS pattern. But in general, we do it in supine position.
Is it clinically relevant if there is vertical or horizontally collapsing IVC?
That's a tricky question because we don't know. So the theoretical part is that like almost all the studies that looked at IVC collapsibility were done using a longitudinal view of the IVC because they were done by cardiologists. Cardiologists don't do transverse view of the IVC; they just do longitudinal view. But we do know, as more and more people do POCUS now, we realize that there is transverse view of the IVC, and you can fall prey to the cylinder effect when you're doing the longitudinal view of the IVC. And IVC collapse is not necessarily in anteroposterior diameter, but generally in most patients it's anteroposterior collapse. Rarely you can have, like in the other picture I showed, you can have lateral collapse. So if you don't do lateral view, you will miss that collapse. Whether it's clinically relevant or not, I don't think it's ever been really studied because it's only a few patients that have. It's just like you remember that as one of the exceptions and you have to evaluate in both views. I don't think there is a formal study looking at that. But in general, most people, it collapses in anteroposterior direction.
Okay, can I just ask in this context, I mean, what's the role of abdominal pressure on the IVC diameter in terms of like someone who's got ascites or someone who's got sort of abdominal compression syndrome of whatever? How does it affect the IVC diameter?
So IVC diameter typically becomes smaller in cases of raised intra-abdominal pressure. So your IVC alone might not be trustworthy in those cases. That's why you have to add on abdominal Doppler. Say if you do renal venous Doppler, if there is raised intra-abdominal pressure, you will see increased pulsatility. So then, yeah.
Okay. Yeah.
So you add more parameters. So there are definitely exceptions to every parameter, and especially IVC is prone to so many exceptions.
Absolutely, yeah. And the question, what do you recommend when patient has already pulmonary edema, but with IVC collapse, like severe plasma leak?
That's a tricky situation, but first I would want to make sure that the lung pulmonary edema is really cardiogenic in origin. And if that's really happening, then the left heart is like completely dead, and right heart is still working, which is kind of unusual. Then that's why I want to make sure it's all cardiogenic pulmonary edema. Then really look at the left ventricular filling pressures, do the right heart cath if you need to do, and then see what you can do to increase the left heart contractility. Yeah. And but I mean, obviously, indiscriminate diuretics is going to hurt the kidney function. You just have to achieve a balance as to. It's very unlikely that your IVC is like 1 centimeter and 100% collapsible and lungs are filled with B lines. That's like very unusual. Probably you're dealing with some kind of infection, ARDS kind of picture there. Because I cannot imagine a situation where right heart is so good and left heart completely failed.
Yeah. So I guess the other way around is possible, where you have left, like diastolic failures, where the left ventricle, there is increased pressure, back pressure, but the right ventricle seems to be okay, where there is sort of congestion within the lungs.
And it could be temporary also, right? If you're just talking about just diastolic dysfunction, it could be just flash pulmonary edema in a patient with hypertension. You just give antihypertensives, that pulmonary edema goes away. And rarely it happens that if you really saw this situation, like if you did see that like there is diffuse B lines and IVC is small and collapsing. Other thing I really worry about is in hyperdynamic hearts, you can have systolic anterior motion of the mitral valve. If you remember the parasternal long axis view, the mitral valve is so close to the aortic valve, like aorta and mitral valve are just side by side, right? So in hyperdynamic hearts, during ventricular ejection, the mitral valve leaflet can obstruct the LVOT, that systolic anterior motion of the mitral leaflet. And that's when you can have pulmonary edema, like back pressure into the lungs and completely collapsible IVC. But excepting these situations, like acute situation with hypertensive urgency and systolic anterior motion, I cannot imagine a situation where you have so much discordance.
Yeah. So next question, can ultrasound be used for fluid management immediate post-transplant period?
Yeah, of course. Yeah, it's applicable. Essentially, it's the same body, same thing, right? I mean, you just have to pay to minor details such as the patient could be mechanically ventilated or coming off from the anesthesia effect, and some things could be transient, and some vasodilatation can be transient. But yeah, in general, yes.
Great. So there are some accolades from Dr. Manisha Sahib. She says, nice presentation, especially explanation with physiology behind it. POCUS is another tool in nephrologist's toolbox and should be used along with clinical cues and clinical setting. I completely echo that view, and it's a fantastic presentation. So there are a few.
Dr. Pani, there are a few more questions in the question and answer session. I think you can just take the questions too.
Yeah. So there is a question from Dr. Min Ong Hain. Very keen to listen and learn another lecture when it will happen and can get notification. Thank you very much. So this is probably a question for Dr. Manjusha.
Yeah, there are questions in the question and answer session. Just I'll put forward. This is a question from Dr. Pradeep Abhilash. Can you guide on position of arm while doing lung ultrasound? Like in a critically ill patient, what should be the position of the arm while doing lung ultrasound?
I mean, when you say critically ill patients, it's difficult because they might not be cooperative. But in general, if you are talking about a cooperative patient, you just ask them to like put your arms like that. So that will allow you to assess the lateral zones easily. But critically ill patients, you get what you get. Like, I mean, but you just make sure that you soon auscultate the lateral zones.
Yeah. And there's another question. What is the gold standard to predict fluid response, and how do you measure stroke volume?
That's a whole different topic. I wantedly avoided that to keep the talk short because we didn't talk about Doppler basics and stuff. But in general, you assess stroke volume by pulsed wave Doppler. Pulsed wave Doppler allows you to measure the blood flows at a particular point. So you go to the left ventricular outflow tract and you get a tracing. And I think it's a whole different topic. But yes, you can relatively easily measure stroke volume at the bedside. But the prerequisite to do everything, you can do a lot of echo. Like you can do echo as good as a cardiologist with enough practice. But the basis for everything is learning the basic views. If you don't get the basic view right, if you get a tilted view or a twisted view, then all your measurements are waste. Like they don't work, because for Doppler you need to have good angles, preferably parallel angle with the blood flow. And if you will achieve that only with good grayscale images.
What is this concept of tri-POCUS approach that you had mentioned in the literature? Like, I mean, to assess a patient completely with respect to the volume or something, you need to assess lung, heart, and veins. I mean, is it like that? Or can we do as, independent section, like the way you have spoken about today? Like, I mean, focusing at lung, focusing at heart, or should we is it all, it's understood that physiologically it's interdependent, but is it mandatory for us to do this approach for us to understand in a comprehensive manner?
No, that's definitely, we need to use multi-organ point of care ultrasound. The tri-focus approach is nothing but the pump, pipes, and leaks. I like saying pump, pipes, and leaks more because it's more descriptive term. Because without all these components are interdependent, and interpreting one in isolation is possible and practical in some instances, but you need to have an idea of other things also. For example, in some of the examples show, like your IVC can be small, but if you have pericardial effusion, you can still cause tamponade if the patient is volume depleted, even if the pericardial effusion is small. So you can't just go by one particular criteria. That ESRD patient with plethoric IVC, you might want to remove fluid, but if the patient has pericardial effusion, that will cause hypotension. There are similarly so many other things that would benefit from doing a combined evaluation of the hemodynamic circuit. But in general, when somebody is learning point of care ultrasonography, then obviously it's acceptable. You can't learn everything in one day. So then you start with something easier. And lung ultrasound is relatively easy because it's only A lines and B lines, horizontal lines, vertical lines. As long as you know exactly, like you're putting the probe right. Again, I'm saying this again, that the probe has to be perpendicular to the chest wall. If you are like tilting the probe like this and like this, you don't get good A lines. Only when it is perpendicular, you are paying attention to the curvature of the chest wall, you get good A lines and B lines. Yeah, so those kind of small things, like as you keep doing on a daily basis, but I think like the first thing is to start doing lung ultrasound. That's relatively easy. And then IVC ultrasound, and then probably focused echocardiogram. But in general, if you really want to master the art of volume status assessment, and so far nobody has mastered, but you need to evaluate multiple organs.
So from a learner's perspective, it is predominantly like to learn the focus of the lung
easier components
at the
first.
outset. Yeah, easier component, right.
So perhaps we need to highlight the point that IVC measurements should be taken in the context of knowing the output from the heart, left ventricular output. So on its own, I guess, is got to be taken with a huge pinch of salt in terms of understanding the physiology as to what is happening to the patient.
But it indeed is a good indicator for right atrial pressure. That should not be ignored. So we commonly say, like, once we do so much Doppler and advanced focus, you might hear some people saying on Twitter and stuff that IVC is useless. But IVC is not useless. Nothing in medicine is useless. It's just that we are using it for a useless purpose, which is fluid responsiveness. That's the problem with that. But IVC is a very good indicator for right atrial pressure.
Yeah. So one last question I have you used POCUS to adjust the dry weight of your dialysis patients on a routine basis, like patients who are asymptomatic or on the verge of going into sort of fluid overload status? Have you managed to prevent such episodes? And is it practical on a regular basis?
Yeah, I think the important part of this question is it practical or not? But yes, so it's practical. And now that we have this like handheld devices, right? And you really don't need sophisticated Doppler or anything to do lung ultrasound. Just the basic ultrasound is good enough because it's just artifacts. I have used, but not on a routine basis. The problem is that all the data you have in dialysis patients is using the 28-zone ultrasound. The authors wrote a letter in AJKD also, is it really practical? But the author said it takes only about 5 minutes or so. They gave some time. I don't think it's really possible in real outpatient dialysis unit. The reason is the dialysis chairs, first of all, are not really that comfortable. Not comfortable for patient, not comfortable for your back also. You'll injure your back really, like if you indiscriminately do POCUS, like bending, doing all those things. You should never injure yourself. It's a real thing. Yeah, occupational hazard. And second thing is that you have to when you're looking at multiple zones in acutely asymptomatic patient, you're just looking at 2, 3 zones, 4 zones, 8 zones. That's good enough. But in dialysis patient, if they are not symptomatic, you want to scan more zones, for which you have to remove the shirt, right? We remove the top. So if you don't have, your dialysis unit does not have screens separating the patient, that can get tricky. Especially with female patients, it's even difficult. So these are all practical problems, like injuring your back and exposing the chest. And some dialysis units have a separate room you can do, like before the patient is put on the machine, you can do like whole body ultrasound, even using Doppler if you want, but that would limit the number of patients you would do this on. So that's a practical problem. Yes, like you asked, like in selected patients, if you want to do, who are prone to having, who you think they're on the higher side or who are prone to having recurrent admissions, those patients selectively you can do. But in a whole dialysis shift where you have 25 to 30 patients, you cannot do on every patient. That's my personal opinion.
Yeah. Is there any single parameter on which you depend on, to assess the anticipation of a better dry weight? Like, I mean, as usual, you said in a session, good number of patients will be there. It's difficult for us to assess each and every patient, but is there any single reliable parameter? Like, let's say presence of, taking the lung ultrasound, or probably looking at the IBC to predict the dry weight and not excess of fluid which is present in the body or something?
Yeah, no single accurate thing, but instead of doing 28 zone lung ultrasound, you can always do 8 zone lung ultrasound. Recently, our colleagues from University of Pennsylvania, they looked at it. They compared the 28 zone ultrasound versus 8 zone ultrasound in dialysis patients. They found it's relatively, it retains its prognostic value. So you can still auscultate the lateral zones and it's still okay. And in addition, I would recommend looking at the inferior vena cava also. And inferior vena cava, you get from subcostal view, that's normal. But when the patient is lying down like that in the dialysis state, it becomes very difficult, especially with distended abdomen. So the easier way to get IVC is go to the lateral aspect. Go to lateral aspect where you see the liver. There you can find the IVC. And when the patient is sitting this way or this way, in the left lateral position, you can easily get IVC there. So I think you should use both IVC and lung, because it's always a criticism, right? There are so many studies using lung ultrasound because lung ultrasound is easy but it's not really a reflection of intravascular volume. You can have B-lines in the lung because of the left heart issue. And during dialysis, we are removing intravascular fluid. So I think without seeing IVC, it's a little tricky to just depend on the lung ultrasound to adjust dry weight. I mean, the most awaited LUST trial has come out, right? They were looking at patients with high cardiovascular risk and adjusting dry weight based on lung ultrasound, whether it improves mortality or not. So basically, it turned out to be a semi-positive trial. It was not really positive trial in the sense that the mortality was not changed if you do adjust dry weight based on your lung ultrasound. But at the same time, it reduced the number of hospital admissions for CHF patients. So in one way or the other, it's better. But I think the problem is over-reliance on one single parameter and not paying attention to the intravascular volume. Because that's what exactly you are addressing during dialysis, right?
Dr. Abhilash, great discussion. Thank you very much. Excellent presentation. So I look at it this way. The teachings, what you've imparted here, they should be imparted to all of us so that even if we are not doing the procedure ourselves, it helps in better interpretation of the findings mentioned by other people. So as a background, all of us should be exposed to these classes. So that's a good point. And I think a day has come when so many nephrologists are passing out. Maybe some of them branch into this field, intervention nephrology, and this is made a part of that. And we have some minimum number of sessions. So we master the art of doing. You have shown so many points. I mean, you have shown pictures and very beautiful, but I think it will take us some more sessions and I think more practical sessions to become adept at doing it and interpreting all of it ourselves. So I think a section of the younger generation people can focus on this, especially those who work in intensive care and in nephro-intensive care units. I think that day has come because so many nephrologists are there. People can branch out and focus maybe on this modality, because focusing on this may not be possible for the radiologist, a busy radiologist, not for a nephrologist who is looking after everything. So all of us should know about this, and some of us maybe can specialize in this. And the third point is, could we have a similar class on AV fistula as well? I mean, that's also very relevant for the nephro, at least the bedside interpretation of the AV fistula using the imaging tools. So that also would be great and excellent, and really, really thank you very much.
Yeah,
thank you. Yeah, that's a good point. That I actually, after learning Doppler echocardiography, I'm interpreting the cardiology red echocardiograms much better. And obviously, you can't call cardiology to do echo every day, right? And patients' hemodynamic are really dynamic, so you have to have a understanding of how it is changing on a day-to-day basis, more pertinent in intensive care unit, but also in my experience, it's very relevant in regular floor patients also, because the goal is not for the patient to end up in ICU. So you want to prevent that deterioration. And yeah, I mean, yeah, ideally everybody has to get acquainted with that. Only practice is the way to do that. And interventional nephrology, it depends. I mean, interventional nephrology here is primarily about access and people who are interested in doing procedures, but not rest of the POCUS, right? It's a misconception actually in some parts of the US that interventional nephrology should know POCUS, but that's not the case. It's a completely different thing. Intervention is something, it depends on your interest. If you have procedure bent of mind, you do that thing as your primary specialty. If you don't have procedure bent of mind, you don't. But POCUS is physical examination, so it does not really, it's not specific to intervention. And regarding the talk about AV fistula, I'm not really the expert in AV fistula. I do the basic bare minimum thing, but I'm not the expert who would, like, if you ask me anything about echo or these things, I know in and out because I have done so many. But fistula, I'm not really the one. You might want to get some interventional nephrologists with expertise on AV fistula, because practically in my practice, I don't use it that much. Only purpose I scan AV fistula is see if there is any acute compliance, say if there is any clot or if there is any extravasation of the blood or the patient complains of pain, pseudoaneurysm, those things I look at. And in the CKD5 patient is coming to the clinic, I want to know if the newly placed access is mature or not. So I do some Doppler and look at the flows and see how is the flow in that. So that's it. That's what I'm restricted to. But if you ask me complicated questions, I don't know.
Abhilash, at this point of time, I think, I mean, there is another area which I think has been a little untouched, right? That is vexus, I mean, venous, yeah. I mean, maybe, I mean, as you had the outset said that, I mean, you'll not be comfortable in speaking about the AV fistula access as such at the outset. Is it possible for you to speak to us about the vexus? I mean, probably in future, I think we'll plan and get back to you. That's one thing. There is another information from a group of doctors, nephrologists from Philippines. They have indeed appreciated the talk very much, and they would like to invite you over to the Philippine group too. Probably I will communicate to them regarding how to approach and all these things. But nevertheless, it's an excellent talk, Dr. Abhilash. I think a lot of information has been embedded into it. As Manisha has said, it's not easy for us to imbibe so much of information in, like, I mean, 2 sections or something like that, but definitely a good amount of information has been given to us, and practical approach definitely will be different, isn't it? I mean, unless you have hands-on experience going on doing it, you'll not be able to, I won't say achieve an expertise, at least learn some basic concepts in the POCUS in nephrology. So I think we should all intend to, few institutes have an ultrasound machines as well. Probably having a hands-on experience in them and then learning will help them a lot. Pani, any other questions are there, Dr. Sri Pani?
No, I think that's it really. It's a fantastic presentation, Abhilash, and good luck with everything.
Thank you.
Thank you, Abhilash. Yeah.
Thank you. Yeah, it's all about practice, like you said. And, that's why I say, I mean, theoretical aspects are there. They are on nephropocus.com. You can go back and listen to lectures if you really have time. Look at all my things that I write. And in general, when I see an interesting case, I put that on the website too. So, but the point is continued practice. And that's why it's important that if you have some images, like we can do like case presentation sessions by your residents and other people who are starting to learn. That way, just by looking at the image, most of the time, I should be able to tell you like if your proposition is correct or not and what you're doing wrong. In most cases, may not be in everything. So that way you should not hesitate, because when learning, obviously I learned it on my own too. It's not that I'm trained during fellowship, right? So I shadowed everybody without any issues. I shadowed sonographers, I went to radiology, I went to critical care. So I did not hesitate to learn from anybody. So I think like discussing some cases would be something useful. Yeah, but yeah, thank you so much. And yeah, I'll be happy to talk about vexus in the future, because that's my primary interest. Actually, that has become my primary interest, where like people from other specialties are also like wanting to learn. So yeah, that's going to grow. Thank you.
Thank you. Thank you, Abhilash. Thank you, Dr. Sirapani, for being with us. Thank you so much, Abhilash. We'll definitely get back to you with further information regarding, to speak to us in forum. Thank you so much. And
Sure.
Indeed a great talk. Thank you. Good night. Good night.
Good night.
Thanks. Good. Thank you.
Thanks so
Krishna
much.
sir, thank you. Good night.
Thank you.
Good night to all.
Sure. Thank you.
Good night. Good night.
Bye-bye.
Ma'am, this recording program, I'll try to send it to you in Google Drive or something so that you can share.
Please send me the link so that I can circulate to everyone.
Yeah, sure.
Done. Good night.
Thank you.
Good night,
Thank you.
Manisha. Good night.